I have agreed to deliver today's lecture, and I will be sharing my screen shortly. So if you can just give me a few seconds. Is everybody able to see it? Slideshow.
Hi, Waseem.
Hi, I'm just
Can I
trying.
please introduce you first?
Thank you. I didn't know who was going to.
It's me.
Right.
Okay. Good afternoon, colleagues, and welcome to the Social Responsiveness lecture. Today, as part of Suicide Awareness Month, we have our guest speaker, Waseem Hawa, speaking to us about suicide prevention and awareness program of Valkenberg Hospital. And to tell you a little bit about him, I mean, I'm sure you all know him by now, but Waseem Hawa is currently the principal psychologist at Valkenberg Hospital. He's a lecturer in the Department of Psychiatry and Mental Health. He's also the chairperson of the Division of Psychotherapy, the convener of the Child Criminal Capacity Assessment Service, and he has extensive work experience in correctional services, as well as Lentegeur Male Acute Unit. And so over to you, Waseem. Thank you for availing yourself.
Thank you so much, Fatima. I'm just checking if my screen is shared.
It is shared. There's nothing on the screen. Is that
blue,
correct?
is
Yes,
it blue?
that's correct.
Okay, there we go. Thank you so much, Fatima. So let's kick off. I'm hoping you can see my beautiful curtains. So today I'm going to be chatting about a suicide prevention and awareness program and questioning whether it is an example of social responsiveness in action. So just to begin off a little bit with the data, more than 700,000 people die by suicide every year, with an approximate 20 suicide attempts for each one of those 700,000 in terms of the ratio. So it can occur at any stage of life and in all regions of the world. In 2019, suicide was the fourth leading cause of death among 15 to 29-year-olds. Globally, with 77% of all suicides having occurred in low and middle income countries. Almost 20% of global suicides were due to pesticides or self-poisoning. So I think it just speaks to the importance or how critical this issue has become. If we move further, we'll see how the stats keep changing, which is the connection between active suicidality, previous suicide attempts, and mental health conditions is well established in high-income countries. So we do know that once we've seen one suicide attempt, especially in instances of mental health, increases the likelihood of future attempts. There are, however, also numerous attempts which happen impulsively in moments of crisis. And I think these are not unknown to us in terms of what could be the trigger for a suicide or suicide attempt, which includes experiences of loss, loneliness, discrimination, relationship breakups, financial problems, chronic pain and illness, violence, abuse, and conflict, many of which are features of our society here in South Africa. Stigma around mental health conditions and suicide, however, often results in many people who are contemplating suicide not seeking help. And I think that's one of the major issues is the person reaching out? Are they communicating their feelings? Do they know who to reach out to? And when the time has come for action. So suicide and suicide attempts have a collateral effect that impacts on family, friends, colleagues, communities, and societies. I think it's very important at this stage also to think of the cultural and the religious views of different populations in terms of how a community may or may not respond to suicide. In my own clinical work, I have had to work with the bereaved members of someone who has committed suicide, specifically with regards to the Muslim community and the challenges that the stigma around suicide holds within Islam. So just speaking from a clinical perspective, working with individuals in my own population, in Islam, when a person commits suicide, they're not allowed to be buried as per normal Islamic rite. There should be no religious ceremonies of any kind. And often that is the very devastating consequence for the bereaved in terms of not being able to mourn for their family members in the way that they are culturally accustomed to. And I imagine it varies with different religions and different cultures. In 2021, the South African Depression and Anxiety Group reported that there were 23 known cases of suicide in South Africa every day. And for every person that commits suicide, 10 have attempted it. Before COVID-19, SADC received 600 calls a day. I know this was mentioned in a previous lecture by another colleague. As of September 2021, that number had risen to 2,200 calls a day, an increase of nearly 40%. And I think we could speculate on the impact of COVID, not just the lockdown, but the economic toll, the loss of loved ones, how that affected the state of mind and the psychological well-being of people in South Africa as across the world. So in 2023, the South African Society of Psychiatry says that South Africa is ranked number 10 on the list of countries with the most suicide. Currently, there's 23.5 suicides per 100 people. Of the 13,774 suicides reported in South Africa, 10,861 were amongst men, demonstrating that suicide appears to be more prevalent amongst men. And one might already start asking questions in terms of cultural norms of accessing help. One might ask the question, are men more prone or less prone to accessing or engaging in help-seeking behavior? So in 2023, we were tasked with responsibility by the hospital of taking on Suicide Awareness Month. And we developed a program, well, an activity focused on suicide prevention and awareness. It was implemented in 2023, not 2022. It adopted the Western Cape Department of Health messaging, which espouses the World Health Organization's triennial theme, which was creating hope through action. And this just really speaks to their narrative around the theme, which is it serves as a powerful call to action and reminder that there's an alternative to suicide. And through our actions, we can encourage hope and strengthen prevention. By creating hope through action, we can signal to people experiencing suicidal thoughts that there is hope and that we care and we want to support them. So this is lifted directly from the World Health Organization. It also suggests that our actions, no matter how big or small, may provide hope to those who are struggling. So the program effectively involved a 15-minute talk with the opportunity for the audience to engage. There's a general waiting areas in 11 community health clinics and 3 district hospitals, in addition to spaces within Valkenberg Hospital. Senior personnel and intern psychologists delivered the same talk in the same week, in which the Western Cape Department of Health and Now Wellness and WHO had designated a suicide presentation and awareness day. Consultation occurred with facility managers and mental health nurses in terms of preparing for the day. Individuals in waiting areas were prepared on the day in the clinics. We utilized our own department's poster and a visual aid, which was endorsed by our comms office in terms of ensuring that it was consistent with the messaging that was to be sent through. Was also utilized. There were also pamphlets that is produced by Western Cape Department of Health and Wellness that was also made available on the day. I think we printed over 1,000 pamphlets that were then made available, and the posters were left in the clinics. Visual aids were only used for talking points and were then returned. Sorry, I'm trying to move to the next slide. So the audience members, part of the structure for the day, could also access the intern psychologist directly on the day or via mental health nurse. Visual aid and research into the talking points were developed by the intern psychologists. So they were tasked with engaging with literature and developing a talk that would speak to the overall narrative. There were multiple group meetings here at Valkenberg and a review of existing literature and guidelines to open format talks, which I will speak to in terms of both risk and benefits a little bit later in the lecture. So the talk really emphasized accessing services. All audience members were invited to pose questions and provided pamphlets. Any further queries and access would be granted to the intern psychologists in both the district level hospitals and the community health clinics. Response from the staff and the audience appeared to be quite positive in terms of the verbal feedback given. So this is anecdotal feedback in terms of having discussed it with mental health nurses, with the interns, and hear what feedback they receive from the actual audience members on the day. No incidents were reported from any of our interns at the different sites. So this is just a picture of the official health department's poster, which is the theme is Let's Talk. What was very interesting is that to adapt one for us as the current or the then current poster only spoke to youth and adolescents. And so we were having to repitch it for adults, so minor changes had to be made. We then also used a visual aid which was put up for the day using the title Wait Mzansi, which examines warning signs, the questions to ask, emphasizing the message that it can pass, also talking to others, and then also looking at what are some of the strategies and thoughts that we can utilize. And I think we placed quite a lot of emphasis on accessing mental health services and making that available. So this is a picture with all of the patients' faces who were in the audiences. This is just 4 different settings, just to give a sense of what it actually looked like, using the waiting areas of the different clinics. Just providing a bit of a sense of what the interns were presenting on that day. So what is the value and risk of psychoeducation in suicide prevention? So it has been found that the impact of psychoeducation connected to suicide, when appropriately implemented, is not harmful or dangerous. It can in fact be advantageous in reducing suicidal ideation, enhancing understanding of mental health, and encouraging help-seeking behavior. The value add is that it may diminish suicide risk by increasing awareness, lessening stigma, and promoting individuals to seek help. However, it's important to note that these interventions are usually part of a broader, comprehensive approach to suicide prevention, which has shown positive outcomes overall. So when it's taken into a larger program, an approach that's a departmental guideline or SOP, an intervention strategy that is more holistic, there is much more value added. The key to its effectiveness also lies in the thoughtfulness and sensitive delivery of the content, ensuring that it meets the needs of the audience and is supported by trained professionals. And I think it's important to note that there's been a lot of questions around media campaigns in suicide. This is not effectively a media campaign that's being generated by non-clinicians. These were intern psychologists who were 9 months into their training with us, following their M1 year. And I think part of our training here is how we manage suicidality, the type of, the nature of the language which is utilized. So the potential for harm, and there is definitely potential for harming, is minimized when these conditions are met. And caution is advised, particularly when dealing with high-risk populations. And I think a lot of work that has been spoken about by Jason Bainchis that also speaks to the current reference that I've utilized here is the idea of gatekeepers in suicide prevention awareness programs in terms of individuals who are trained to flag indicators of a potential suicide risk. So public messaging about suicide prevention is currently a key communication strategy for educating individuals about warning signs and resources available to help individuals at risk for suicide before crisis occurs. Safe messaging emphasizes that suicide is preventable and promotes action and resources for prevention. And there's actual guidelines for how the media engages with the topic, specifically speaking about the sensationalization of language, which may actually trigger further trauma. And it's useful that these guidelines be, or actually indicated that these guidelines be utilized in any sort of public campaign. So what about the use of open format workshops in suicide prevention, awareness, and psychoeducation? So short focused interventions can be useful in raising awareness about suicide prevention and may reduce stigma and encourage help-seeking behaviors. The effective psychoeducation delivered in open format workshops to the public on suicide indicates that such interventions are not harmful or dangerous when conducted with the appropriate safeguards. The effectiveness and safety of these interventions depend on several factors, including the content of the psychoeducation, and for us to be avoiding triggering language, for us to be focusing on the alternatives, for us to be focusing on how to access services, and not to utilize language that may exacerbate trauma. The qualifications of the facilitators and the support systems available to participants is also critical. Open format psychoeducation workshops on suicide can be safe for the public when delivered properly. So in terms of evidence for supporting these brief interventions, it's highlighted that what has been highlighted that these interventions can significantly increase awareness about mental health issues, including suicide prevention, when presented in accessible environments like hospital waiting rooms, and can effectively engage individuals who might not otherwise seek mental health care. So we'd moved out of the space dedicated for mental health and into the general waiting area. Study emphasizes the importance of content that is clear, concise, and tailored to the audience need, which can lead to improved knowledge and attitudes towards suicide prevention. And I think in this case, if we're dealing with a population that is diverse, the language needs to be relatively neutral and focus on help-seeking strategies. It also suggests that short targeted interventions are effective in reaching at-risk populations in public settings. These interventions can increase their awareness of mental health resources and provide immediate strategies for managing distress, which are crucial components in suicide prevention. And then finally, in terms of the long-term effects on participants' mental health literacy and their likelihood of seeking help, there's long-term benefits in these interventions. It does, however, integration of such interventions in public spaces, noting that they can be a cost-effective method of suicide prevention with broad reach. There are queries about the long-term durability or the retention of this knowledge and its impact on suicide over a long-term period. So the value of these workshops would be more beneficial if part of a broader public health campaign aimed at suicide prevention and a program. The safety of these workshops largely depends, and I think it's important to emphasize this, on the facilitator's ability to manage the content sensitively and provide support to participants who may be triggered by the material. So on this particular day, we also made space during the day that if anybody wanted to access the interns in terms of things that may have been triggered, that space was made available. Reviews emphasized the need for facilitators to be well trained in handling discussions about suicide, ensuring that they can provide appropriate referrals and support if distress arises. So if one were going to task shift, one would really need to look at the current training programs available and ensure that any person who is taking on this responsibility understands how to engage clinically with suicide and suicidality. We can't avoid the potential or can't minimize the potential risk, which is distress among vulnerable individuals. While it can generally be safe, there is a concern that they could cause distress among particularly vulnerable individuals in the audience. If the workshop content is too explicit or if it triggers unresolved trauma, participants might experience increased anxiety or suicidal thoughts. It's thus crucial that these workshops include clear guidelines on how to seek help and that support is readily available during and after the sessions. So this was done in conjunction with the mental health nurse. So we had two clinicians present. In some cases, there were also other clinicians present. So, sorry, I can't make up my own heading here. Is a psychoeducation talk on suicide prevention and awareness and active social responsiveness? I think the argument that can be made is that it addresses public health needs. Suicide is a significant public health issue, and hospitals often encounter individuals at various levels of distress. And providing this education in terms of awareness in such a setting directly addresses a critical need for mental health awareness and intervention. By offering this information in a general hospital where people are from diverse backgrounds and circumstances where they gather, the initiative reaches a broad audience, including those who might be at risk or someone who is at risk. In terms of promoting mental health literacy, enhancing the public's understanding of suicide, its warning sign, and the resources available for prevention can empower individuals to take proactive steps in seeking help for themselves or others. I sat in on some of the groups and it was very heartening to see the response of the audience in terms of the additional knowledge that they were gaining, the information around resources that they could make available to others. So this educational approach aligns with social responsiveness by, apologies, I have another lecture immediately after this. That's why it's going off, by promoting mental health literacy and encouraging supportive behaviors within the community. So it's also about reducing stigma and encouraging help seeking. Discussing suicide openly in a public space like a hospital can help reduce the stigma associated with mental health issues. When people see that suicide prevention is being addressed in a respected and professional manner, it can normalize conversations about more mental health and encourage individuals to seek help, either for themselves or for loved ones. This act of social responsiveness helps create a more supportive and informed community. And then the final argument to be made is that it's responsive to the needs of diverse populations. And it speaks to the fact that our hospitals have people from all walks of life, and providing psychoeducation in this setting ensures that vital information on suicide prevention reaches this multicultural and diverse population, which is crucial for effective public health intervention. This inclusivity reflects a socially responsive approach to addressing the mental health needs of a broad population. So just in terms of my concluding comments, psychoeducation talk on suicide prevention awareness in the hospital waiting area, in my opinion, can be considered an active social responsiveness. It aims to address serious public health issues and advocates for mental health literacy, lessens stigma, and is accessible to a diverse audience. It should, however, form part of a larger coherent framework for intervention. And I know, having worked with Jean-Pierre Hartmann, he's working with Dr. René Nassen on a framework or an SAP for children. And I think that's something that we really need to be thinking about within the department in terms of what is our larger intervention strategy across the lifespan. Additionally, the delivery of these talks should be given careful consideration and factors to mitigate risk needs to be put into place. So I think one should tread lightly when approaching this topic. It needs to be respectful, it needs to be thoughtful, and one does need the skill set to be able to manage a crisis as it emerges within the space. So although there are benefits, there are also risks, and it's how we plan for those risks. And then just all my little hundreds of things that I've read and drawn from, which brings us to the conclusion of, I think, a very short little talk, which I suppose is in keeping with the idea of a brief intervention. With that, I open the floor for discussion, questions, queries. Fatima, I hand over to you.
Yeah, thank you, Waseem. That was quite enlightening. And